Good afternoon, everybody. It's been a real pleasure that I've seen some people I didn't expect to see, or connecting with folks I know from other places, and so that's been great. I feel a little bit out of place here in that so much has been about technology, and what I'm going to talk about in my presentation here really is a kind of the low-tech approach to social networking and community engagement. I'd like to acknowledge I've been doing this work now well over a couple of decades, and wanted to acknowledge that the sponsors that are currently or in the fairly recent past have supported some of this work here. And because so much of this is community-based work, it would not have happened without all the engagement of the various partners that you see here. So that brings me to the question, to start this off here. So why are we interested in social networks and communities as a way of initiating change? And for me, it boiled down to someone being a primary care physician, a family physician, trying to deliver primary care in a busy clinic that's primarily Medicaid population. It's really faced with, there are a lot of people who don't come in or can't get in or don't want to come in for various sorts of reasons. And then as I started working with other community agencies and some worksite and wellness programs, then what about those people that are not part of the active workforce, but yet they're responsible for generating a significant amount of the healthcare claims, and those are dependents. So how do you reach those folks? And when I talk about barriers to access, they're not only geographic, but they're also linguistic and cultural. So the answer to those, in my opinion, is to really reach people where they are. And social networks, I don't need to really say a whole lot about that to this group. I think people here really buy into the idea that they're important. But just specifically in the area of smoking cessation, which is what I'm going to focus on today in this program I'll talk about, there's a very powerful effect of social networks on decreasing the probability that someone's going to smoke. And it also, this idea of cascades of quitting, that someone will initiate quitting smoking and then others in their social network will do the same. And it extends out to 3 degrees of separation. I saw this diagram in a New England Journal paper a few years ago, and I was really fascinated by this because it really kind of gave a graphic to a lot of those things that I see and sense as a researcher and then also as a clinician, and that we are linked on so many levels. In a molecular level, disease processes are linked, and I think we've seen that in some of the approaches to behavior change that some of our other speakers have spoken about. Diseases are linked. We've had a lot of talk about obesity as well as other behaviors here. And then we've talked about people and the social network revolution that's happening there. But as I looked at this, because I'm a public health researcher, I realized there was a level missing here from my perspective. And Hello? Okay. That there's another level that's above the individuals that are networked, and it's really the organizations and communities that really form the fabric of that environment that our patients are living in. This is some of the, what I'll take you through is some of the underlying sort of thoughts and theories that have led to the Helpers Program intervention that I'll speak about towards the end here. That is an example of engaging community networks as well as social networks. So quitting's not always planned. We used to think that in tobacco cessation, that it was a planned behavior, but it's not. And it's often unplanned. Surprisingly, some of the unplanned attempts are more successful, and also that they're likely to be acted on immediately. So that brief interventions, so these small conversations, these short conversations, can actually have quite an effect. And although intensive services are important, brief interventions are an important part of that whole continuum. And because they're brief, they're low impact, but they have potentially very high reach. And there's been some elegant modeling work done by Shuhong Zhu in California that says it's not just getting people to use intensive services. What's more important is getting more people in the population to even try to quit. And that, in the end, is going to increase your quit rates overall. So it's about getting people to try more. So in order to do that, we need to change the social norms, making quitting normal and making the idea that it takes more than one time for a lot of folks. So keep trying, don't give up. And that because of that, to inspire more hope. And by having knowledgeable people out there to reduce those barriers to cessation aids, it would increase the probability that someone's going to be successful. So that brings us to the idea of helpers. So who are they and what are their roles? We started out calling them health influencers, and those are really anybody, anywhere that's in a position to try to influence someone else's health behavior. So you can see it's a pretty wide range of people. And in the studies that we've done, in some cases, it's even strangers, not people that you would think. The thing they all have in common is they have motive, they have opportunity, and they're engaged. So what do they do with that motive, opportunity, engagement? One of the things that anthropology tells us, some of my best friends are medical anthropologists, that decisions around health are made in the context of essentially social networks, household and family networks. Speaking to some of the ways that we filter information and make decisions. That these helpers can be the trusted members of the community who are known entities, and they are members of the community that are, for whom the intervention was designed in the first place. And they can also be proxies seeking help on behalf of someone else. The California Quit Line, which serves a huge number of people, 7% of all their callers are actually calling on behalf of somebody else. The interesting thing about this number grows up dramatically for those non-English speaking lines. Another philosophy, I would say, that goes underneath helpers is that tobacco is a process. It's a journey, if you will, and it starts with even a small step. And so the helpers and their role is that they encourage maybe that initial step to start thinking about quitting, maybe the last step to actually pick up the phone and call the quit line. Maybe it's just not giving up when someone gets discouraged. They relapse, let's try again. So what is the helpers program I've been talking about here? It's a research-based program that's been developed at the University of Arizona over a number of years of research. And essentially, it's a training program that provides support and resources for someone to learn how to have a helping conversation to help someone else quit tobacco. That the idea behind helpers is that we will foster communities of practice of people that are engaged in the topic of wanting to help someone else quit and wanting to get better at doing so. It has 5 main components. It's training, in-person or web. There's an online community resource center. There's some standard evaluation instruments, there's quit kits, and there's some tested media messages that go along with it. So it's a total package. The helping conversation that I referred to has 4 parts, and this is something that evolved again over our research and feedback from our participants of what it took for them to feel comfortable in this role as a helper. And those steps are awareness. Awareness of someone's tobacco use, either because you asked or you observed or you just know. Understanding, taking the time to understand what their motivators and barriers are to quitting. Helping, and that's actually providing some sort of concrete help to move that person along their way towards quitting. And finally, relating, and that is honoring the relationship and either continuing to offer support if that's appropriate, but honoring the relationship as it is. So the helpers training model is, as I said, it's web-based or in-person. And the in-person part's the part that makes me think that I'm out of place here at this technology thing. It emphasizes a supportive and non-confrontational motivational approach. We found that one of the greatest barriers to helpers was the thought that, I can't read that, how many? 10 minutes. Okay. That was a fear of damage to the social relationship. They're given information and resources and taught skills about how to refer to professional services and to know what those are in the community. So here's some of the research that underlies and is backed up what we've done with helpers. The first project funded by NCI was Project REACH, and this was a community-based randomized trial that compared 2 models of training for tobacco cessation brief interventions. The target audience was basically all comers. If you think about cardiopulmonary resuscitation, what do you do when someone drops of a heart attack? It was that same approach. Anybody in the community can learn how to do this. You don't have to know anything about tobacco, don't have to know anything about smoking. You just have to have the desire to be willing to learn how to help someone else. So the randomized trial, there were 3 groups. There was a web-based training, that was developed in parallel to the in-person training model, and the usual practice group of mailed materials, which is a standard of practice with quit lines if someone calls on behalf of someone else. Our outcome was a percentage of people in each group that actually reported delivering a brief intervention. And we also did extensive qualitative research as well to learn a little bit more about this behavior, what sustained it, what engaged people, what they learned, how they modified their strategies over time. So what did we learn? Who came forward? We were surprised by this. We got a wide selection of the community, and what we were surprised about, not as so much who showed up, because we got people from business, healthcare, behavioral health, education, really every sector of the community you could imagine. But why they showed up was what surprised us. We anticipated that they might show up because it was part of an extension of their job role, their occupational role. That was very much not the case. People showed up because basically altruism. They were interested in helping somebody else. And we sort of tested this inadvertently we ran 2 recruitment ad campaigns. The first tagline was, help someone you care about. People responded to that. And then we ran what we called the Get Stuff campaign. That was participate in research, get some free training, get some skills. The phones just went silent. People aren't interested in getting stuff. They were interested in helping somebody they cared about. We found that the training increased their knowledge, their confidence, and their helping behavior. The surprising thing in this, and looking back on it, we realized that we may have inadvertently converted our usual care group into a minimal intervention group. But this group, unlike what we anticipated based on 2 decades of literature around healthcare professionals, is even a minimal intervention of mailing things caused them to take action. This is a highly motivated, intrinsically motivated group. Anybody that's tried to change health provider behaviors knows if you give them a bunch of pamphlets, absolutely nothing is going to happen. That's not true with this group of people. But we did find that they were not as knowledgeable, they were not as confident about the things that they were doing, but they were out there trying. They all referred to services and discussed medications in a much, much higher percentage than is ever reported for healthcare professionals, usually in excess of 75%. We're referring to quit lines typically. They also discussed medications. And our Board of National Advisors was really concerned about this whole discussion of medications because we talked to them about prescription medications. They said, well, I don't know, lay people talking about prescriptions. And I'm ultimately a pragmatist. I said, well, that horse is long out of the barn. Not only are they talking about it, they're sharing. So we want to make sure that the information out there is accurate and people know what they're doing because they are going to be talking about medications. And then we learned a lot about the contextual influences on helping. And it was essentially some of the tailoring that Vic was talking about earlier, except in real time in the context of the relationship with the knowledge that they have, how they would approach them, how they would time it, what they would say. There was definitely different strategies for different people. The next study, it was a dissemination trial we did in collaboration with Free and Clear. And it was essentially a worksite dissemination pilot. And Free and Clear only did the web components of Helper in this pilot. It was with 3 national corporations. And we were interested in feasibility, essentially of scaling up and utilization. And what we found, it was a 3-month trial that we found in 3 months, and not all the corporations all came along at the same time, that we had really minimal technical problems scaling up, that it deployed across all these platforms without any difficulty. Employees were engaged. In about the 12-week period, we got about 5% of the target population, and not all 3 corporations were participating the whole time. So we learned some things about what are the structures within a corporation that sort of facilitate or inhibit actually putting in an innovation like this. We also, this wasn't one of the main outcomes, but we also tracked who referred to Free and Clear. There was actual a click that they could do to generate a referral level. People did that. We did a follow-up survey that we didn't get a very good response with, but those people that did respond indicated that they were mostly talking to coworkers. but also family members, and they were referring to the cessation services that were provided by their employer. The next study was in New Jersey, and this was
So there you go.
sorry about that. Helpers New Jersey, this was in collaboration with the New Jersey Tobacco Control Program. They decided to deploy both the in-person and web training across all their counties using their system, their pre-existing system, community-based structure of, they call them community ambassadors, but they were based in local community agencies, and they were responsible for promoting the various tobacco control programs. One of the things that we did that was different here was they used the website, but they also used the Helpers Quit kits that I'll talk about a little bit more in a minute. But one of the things that we noticed about them is they became very creative in how they took the Helpers program and what they did with it and how they used it as an outreach tool to engage their various community partners. Somebody went over to one of the universities, I think it was Dartmouth, and they had a professor that offered it as extra credit for all the students. So we're still getting them, and the funding's gone, and they're still doing it. So, and then we kept getting inquiries back from the community people, well, could we do this? What do you think about that? And so there was a tremendous amount of creativity and initiative unleashed by having the Helpers program and having them sort of take it over and make it their own. The Helpers Quit Kits is another way that they could make it their own. We didn't do it so much with this program, but it has a lot of that potential there. They did some customization. This was fun. This was something we developed in conjunction with IDEO, which is a design firm that some of you may be aware of. And one of the things that helped as we worked with them is we really began to think about not only is tobacco cessation a journey, but becoming a helper is also a journey, something that starts with even a lack of awareness that you have any agency whatsoever in influencing someone else's tobacco use, all the way to you become a helper and now you want to expand the circle and spread your knowledge to someone else. So the Quit Kits are designed to really integrate that experience, the helper's journey, with either the training or the
2 minutes.
okay, thanks. Integrate the helper's journey with the web or the in-person training. And it has an outreach or a graduation kit, depending on what's being done at the time. Finally, this is what's going on now. Next week I'm actually going to Maine. Maine has decided to implement only the in-person program. They have a pre-existing system of community-based tobacco cessation clinics and other tobacco prevention activities that they're doing. So they're plugging into this and want to roll it out through their system in each county. The Arizona Department of Health Services in Arizona, they're doing something similar, although they want to do the web, and right now the Helpers website is very closely linked to their Quit line. I'm excited about this with the University of Arizona Health Network, which is the hospital where I work in the system. They're rolling out a tobacco-free campus policy, which I know we're behind the times on that, but they've seen the light. And so they're rolling out a tobacco-free campus policy. But the interesting thing about what's happening is Helpers has become an integral part of rolling out that policy. It is a way of reaching out to the entire employee population. And the goal is to create a culture of promotion of quitting and compassion for people who have difficulty quitting, and not creating a system of anti-tobacco or cigarette Nazis, because we really have patients and their families that we have to think about. And so they're linking that very closely with the free services that the state offers, with the clinical services that they offer through the health network. They're also linking it with free nicotine replacement that they're going to offer for visitors that come on campus. So the whole thing there is really part of their employee outreach, and part of that is also they're trying to reach those employees who have a dependent or a household member that smokes. So this is something that I really have the opportunity to see in our other project is what is the ability to reach beyond the worksite and get to dependents. We think that's happening, but I'll have a better chance to understand it and observe it in this particular project. So finally, back to communities as change agents. I would say that we really do need community-based approaches for all the reasons that I said before. And it's important to engage and activate the social networks. I think they're a resource that's untapped. And one of the ways to, I think, sustain them is to create these communities of practice, which are people linked by common passion for something that they care about and learn more about doing through participatory learning. And tobacco cessation or health promotion can certainly be one of those things. And even though Helpers has evolved out of a decade of community-based research, we're still working on it. And as we get feedback from our communities, it's still evolving. So I don't know where we're going to be in a couple years from now, but I think it'll be a very different place than we are now. So thank you very much.
Question for Jane. This is kind of a technical, very specific question, but if you don't mind, on the new funding that is coming out for the community-based in the interventions, you said that the patient activation measure is a requirement. So I'm curious, truly, it is a requirement, or is the requirement that that there is a process for measuring patient activation and providing tailored content?
It is not a requirement to use the measure in the intervention, but it's how CBOs will be evaluated by CMS. So the evaluation contractor will be collecting PAM scores on patients served by the program, because it's a validated, standardized measure. So what we are assuming, well, hoping or assuming both, is that as long as the PAM is going to be applied to your success, that we're encouraging CBOs to think about using it to guide interventions and risk, that sort of thing.
Yeah. Anybody else?
Yes.
Yep.
Yes, Dr. Brock, thank you for your presentation. Can you comment on how the collaboration is going to change as we go into the future as CMS stops reimbursing hospitals for readmissions, as well as going in subsequent years with the whole concept of bundling that we're starting to hear more and more about?
So you mean collaboration in general among, so this would be just my opinion. I think collaborative process is going to get much better and much more streamlined. If you're talking about ACOs, the Accountable Care Organization movement, I think that there's a lot of experiments going forward. I know in some places what that means is the hospital is buying everything. And there's a lot of, I don't know whether that's good or bad or indifferent. It's probably good in some places and not good in other places. It's a kind of a region-specific thing. In terms of the CCTP is a fee-for-service payment to the CBO who has to have a partnership with the hospital. So clearly within their partnership, they could split that fee. If I were a hospital, I would ask for that because, I would be in charge of making the referral and identifying the right risk patients and that sort of thing. So the hope is that it really is a partnership, but it's going to be compensated fee for service. And I have to say, one of the things that I am hearing, we haven't collected data on this, so a lot of it's just, my impression, but some hospitals are not as interested in the CCTP program because they're waiting for bigger payment reform through ACO. So I think that collaborative process will happen for sure because the payment incentive is very clear. Do you have another impression? I'm just curious.
Well, I guess the communication between the hospital and oftentimes the rehab facilities are suboptimal, and the fact that rehab facilities have not entered into the electronic age where the hospitals and the outpatient clinics have. And there just seems to be a large disconnect between the rehab facility, the hospital. From a personal experience, having a grandmother in a rehab facility, it just seemed that the facility was very quick to call 911 when maybe they could have done something else to prevent that readmission from a personal level. So I'd like to get your thoughts on that.
Yeah, so my hope is that CCTP is, so when you get a whole bunch of provider types together and you say, okay, today we're going to have a workshop on creating a common process, yeah, that is the beginning of a very long effort. A lot of effort goes into that because everybody has their systems and their regulations, and they speak different languages. I know the first meetings we had with hospitals and nursing homes, I felt like an interpreter. Well, what the nursing home means to say is, so they're really different cultures. They view things differently. So personally, my hope is that the CCTP is a little easier. It's the first step to take, acknowledging that it's not total payment reform, it's not bundled payment, it's not accountable care. So it's just a fee-for-service payment that an organization that already delivers home-based services in the community can now get for delivering transitions coaching or other types of transitional care services that's a little less complicated.
I'm afraid that's going to have to be the last one to keep us on track. No, that's fine. That's great. Thank you very much. Let's hear it for the speakers.